Clinical examination of the alimentary system, rectal examination, inspection of the perineum and anus, and digital examination of the rectum completes the clinical examination of the gastrointestinal tract. Rectal examination is essential in middle-aged and elderly adults of both sexes. Without it, the symptomatic rectal carcinoma or polyp will be missed. The old adage, if you don't put your finger in, you put your foot in, as taught by generations of surgeons, still holds good. Indeed, the only contraindications for doing a rectal examination are in a patient with a colostomy, hence has no rectum. So without any rectum, there is no need of doing the rectal examination. The examiner has no fingers, and lastly, if the rectal examination has already been done by someone else. It's amazing, an examiner without fingers. So if the examination has already been done, there's no need of doing it. Also, the findings of the rectal examination are already known. The patient is placed in the left lateral position with hips and knees flexed and the buttocks at the edge of the couch. So the anus and perineum are inspected in good light by lifting the right buttocks and noting the presence of any fissures, skin tags, and dermatological conditions, infestations, and also external hemorrhoids. Gloves are worn and the right finger are lubricated with a water-based jelly, and the pulp of the finger placed flat on the anus. So gentle pressure is exerted. The patient is asked to bed down as though having his bowels opened. The fingertip then slips into the anal canal and is inserted as far as possible into the rectum. The examining finger then sweeps around the rectum to palpate surrounding structures to assess the state of the mucosa and to search for specific lesions. So pelvic structures may be palpable manually by placing the left hand on the anterior abdominal wall suprapubically, also input iliac foci. In the male, the primary landmark is the prostate gland, which is normally of a firm consistency, but with a shallow central groove. The nodular seminal vesicle may be palpable at the full extent of the finger on each side. So with advancing age, the prostate hypertrophies with enlargement and progressive protrusion into the rectum. The enlargement may be symmetrical. Carcinoma of the prostate starts as a hard nodule in the gland, which may be impossible to differentiate clinically from an area of calcification. So as the carcinoma enlarges, it produces a hard, bumpy, irregular tumor with obliteration of the median groove. So with lateral extension, the tumor produces winging of the prostate as it extends beyond the confines of the glands. As acutely tender, the prostate may suggest acute prostatitis. That's when the prostate is acutely tender. Lateral to the rectum on both sides is the ischiorectal fossa, which may be the site of ischiorectal abscesses. Bleme's as metastasis of gastric carcinoma to the rectum is palpable on rectal examination. Posteriorly, it is usually possible to palpate the concavity of the coccyx. In the female, the corresponding landmark to the prostate is the cervix, which, depending on its size and maturity, feels like a firm nodule, like the end of a nose anteriorly. The uterus, depending on its size, may be palpated by manually. Pelvic tumors such as ovarian masses may be palpated on either side of the rectum. In both sexes, the characteristics of the rectal wall must be assessed. When inflamed, as with ulcerative proctitis and also amoebic colitis, it may have a velvety feel. So careful search may be made, or careful search must rather be made for polyps and also rectal carcinomas. And in fact, about 90% of rectal carcinomas must be felt. They may be felt digitally. Most of them can be felt digitally, and small lesions may be papilliferous or nodular, but often only the edge of large ulcerating rectal carcinomas can be felt. As the tip of the examining finger crosses the edge of the tumor, there may be a sensation as though it is then entering a cavity. In fact, this is the necrotic flow of an ulcer. So on redrawing the finger, examine the groove for mucus and blood, and also note the characteristics of the feces, especially the presence of melinous stools. The melinous stools may indicate an upper gastrointestinal bleeding. The feces can be sent for fecal occult blood test if it is not obviously stained with blood. Bloody mucus suggests either an ulcerating tumor of the large guts or chronic inflammatory bowel disease such as ulcerative colitis. So copious mucoid watery discharge may suggest a colonic villous adenoma. In the debilitated or senile patients, spurious diarrhea may be the result of impacted feces. A mass of hard feces filling and also distending the rectum, yet not capable of being evacuated by the patient, could also be present. Softer feces seep around the impacted mass, producing incontinence. Smelly, pale, sticky feces may indicate malabsorption, as in celiac disease, whereas putty or particulated stools are a feature of obstructive jaundice.